Good evening, everyone. I'm Dr. Sita Ramamurthy Pal, President of the Society of Fetal Medicine, Kolkata chapter, and it gives me great pleasure and honor to invite one and all to this online meeting of our Society of Fetal Medicine, where we're going to be talking on a very basic but very important part of ultrasound, that is the 5 to 10 week scan. Now, the early pregnancy scan, we all know, is done very commonly, but at the same time, there are a lot of things that need to be interpreted carefully at this time of the pregnancy, and there are terms that are used very inconsistently and very loosely, which need to be addressed as well. So I'm really thankful to our Professor Emeritus, our mentor, Khurana sir, for getting this across and letting us host this webinar, specially on this 5 to 10 week pregnancy, and which Dr. Aparna Sharma is going to moderate for us, and then unveil what we can see beyond just fetal heart and the crown rump length. What else can we see? How we can address these terms so that we all speak the same language, and also do not cause confusion and more anxiety to the patients by the terms that we loosely use. And slowly, as we will hear as the panel goes around, what we will need to understand and how the guidelines are framing up. So thank you once again, and thank you, Khurana sir, and welcome one and all. Some words from you, sir, before we start off.
Well, thank you very much. I think the words would be more appropriate when we are through with this, because what we tend to believe is that, yes, we introduced the transducer, 3 seconds, heartbeat there, bye-bye, end of scan. And we know that there is much more to this. We must know that we have to respect every scan for every piece of information it conveys. We must learn that, yes, these things are safe. And I'm so looking forward to this program. And I guess we'll have much more to say at the end of the program. But I'm really happy that Calcutta, Bengal chapter took the initiative in this, and we are here this evening, and that we are going to have this interaction. We do realize that we need guidelines for this window, and that nowhere in the world do we have these guidelines. And we're very keen to put these guidelines ourselves. In fact, we have been invited by we have been not invited, we've been guided or directed by the courts of the country to produce Indian guidelines. And so one of the guidelines we're going to have pretty soon is the 5 to 10 week scan. And I think this will be a great time to prepare for that. So over to the program. And thank you very much for giving me this opportunity to be here today.
Thank you, sir. It's our honor for you to be here and guide us. And then we'll move on to the session itself, where Dr. Aparna will be the moderator. And I don't think she needs any introduction in our Society of Fetal Medicine. So over to you, Dr. Aparna.
Thank you, Dr. Sita, and thank you, Khurana sir, for having this idea, planning this meeting, and making this possible. So today we're going to talk about the early pregnancy scan, and the more we delve into it, the more we realize that there is so much to it that we really have to be seeing. Now, and it's also important because we always believe that anything which is well begun is half done, and this is like the beginning of pregnancy. So I think this is something which is extremely crucial in that sense. So today we have with us esteemed panelists and experts, of course, starting with none other than our Professor Emeritus, Professor Khurana sir. We also have with us Dr. Kushagrati Ghosh, who is a well-known figure in this field. We, of course, have Dr. Sita Ramamurthy Pal, who's the president of the SFM Bengal. We also have Dr. Prasanna Roy, who's a very specialist in this particular field. Dr. Mukherjee and Dr. Ananya Basu, both from SFM Bengal, the rising stars of SFM Bengal. So we are really happy to have you all with us today, and let's begin with our discussion, and I would request your expert inputs on all of these things. So what are the questions that come to our mind when we are actually doing a scan in the first trimester? What do we actually need to see? And we know that, eyes do not see what the mind doesn't know. So first of all, we have to know what we want to see. And then what we have seen has to be interpreted, because we might be seeing something which is absolutely abnormal, but we are not able to do it. So the overview of a first trimester scan would be: have a stepwise approach, know the limits of what is normal and abnormal, And from diagnosis to interpretation, how do we, really understand what's happening? So I think with all of these things in mind, I would first begin by asking Khurana sir, who's taken this initiative, and eventually we want to make those guidelines. Is there some disturbance from somewhere, or
Seems to be
it's
some background disturbance.
okay?
Is everybody muted, Vishal? Yeah. Okay.
Okay, sorry. So, sir, I would like to know from you, like when we are looking at a 5 to 10 week scan, what are our goals of this 5 to 10 week scan, so that everybody is on the same plane on that?
Certainly. So first things first, it's not a routinely done scan in almost all parts of the world. And really speaking, it's usually a clinically indicated scan. And we perhaps need to change that. We have to, at this stage then, decide, is there an intrauterine pregnancy? And if it's an intrauterine pregnancy, what is the status of this pregnancy? Live, not live, or maybe become live later. Then, of course, the assessment of an extrauterine pregnancy. And then we go on to dating that pregnancy, recognizing the number and viability of each one of the embryos that might be there. We'll then go on to assess the uterus for anomalies. We will go on to assess fibroids, congenital anomalies, dermoids, and so on. And beyond that, we must understand that we might, if we don't see a pregnancy, correlate with HCG levels. Later in pregnancy, try and recognize molar pregnancy, and make sure that in certain situations, we know which side is the corpus luteum, because if the patient has pain, we know where that's coming from. We'll also learn to recognize heterotopic pregnancies. And beyond the point, we might then also use it for instance, assessing an intrauterine device that is present, and for interventional procedures at this stage, for instance, in certain situations, an ultrasound-guided procedure for evacuation of the uterus. So a wide scope indeed.
Right. Thank you very much, sir. And I think you covered a lot. Actually, this list has been given in the ISOAC basic training protocol. And what I realize is that, you have actually spoken beyond it. And that really brings us to the fact that we need our own guidelines. So I think that's something that has proven the point here to set the ball rolling. So just to look at the broad objectives, there could be bigger, but what we really want to understand is it an intrauterine pregnancy? Like you said, what is the number, chorionicity, confirm the viability, assign gestational age, and then early morphology if possible. But that's something that, again, it's a little questionable. So now we say that, yes, we did think about what is the role of transabdominal, transvaginal, what do you prefer? What do you tell your patients? Do they accept it? Or, and how do you go about it? And just a little bit of basic understanding of, when should you have a pregnancy and discriminatory zone?
Right. Thank you, Aparna, for the
Dr.
question.
Kushal.
Yeah. Thank you, Aparna, for the question. Now, this TAs versus TBS, this TAS, transabdominal sonography, is widely available in our country, and it's easily available and easily done also. And most people are trained with transabdominal scan. But when we are talking about transvaginal, I'm not so sure what proportion of people are actually trained to do proper transvaginal scan. Now, early pregnancy scan actually started with transabdominal, but then we realized that because the region of interest is so far away from the probe, the resolution falls, and therefore it's much better to assess early pregnancy between 5 and 10 weeks by a probe which goes nearer to the target, which means we want to assess the inside of the uterus and immediately the surroundings outside the uterus, which is pouch of Douglas, the anterior pouch, and the lateral adnix and the tubes. And there, the transvaginal probe, being very close to the region of interest, we can use high frequencies. And because of high frequencies, we have high resolutions, and therefore the anatomy is better delineated, and we can come to quickly early diagnosis. Now, having said that, sometimes transvaginal scan, if we just put in a transvaginal probe without assessing the whole of the lower abdomen, we have sometimes missed lesions which are far away from the probe, especially, for example, ovarian cyst patient is coming with pain And then it could be a twisted ovarian cyst high up in the pelvis, which may not be seen on a transvaginal scan, and also maybe a subserous fibroids or a pedunculated fibroid, which may sometimes be missed with transvaginal scan. So I think it in the guideline or whatever in discussion somewhere it might be mentioned that it's better to do a transabdominal scan, assess the lower abdomen before actually putting in a probe inside. Now, of the two, abdominal scan does not need any counseling as such because patients really know that they're coming for an ultrasound, that they know that the lower abdomen will be exposed. But when we are converting a transabdominal into a transvaginal, then I have seen in our unit, for example, there are doctors who would like to take a written consent. So I don't know how much that should be done. But yes, an oral consent and maybe a little discussion with the husband might be worthwhile. We are not saying that you have to write a written consent, but yes, some sort of counseling is important because still people believe, especially in the periphery, that probing with a transvaginal probe can actually cause a miscarriage or a bleeding in a pregnancy which was not existing before. So these are little things which are very important, which needs to be assessed.
Yeah. Yeah, I think so. Very, very beautifully brought out because patients sometimes have a past experience. They would have had an abortion and they would correlate that to a transvaginal scan. And I think those are the things that has to be completely, brought out and told that, okay, this is safe. And you gave a very interesting analogy saying that, sometimes after the ultrasound has come, we have stopped doing the clinical examination. Similarly, after the TVS has come, we have stopped doing TAS. So I think that's something, but we can't really forget our basics and fibroids, ovarian cysts. And I think that's something has to go gradually, very nicely. And anything that you would like to talk about the discriminatory zone, sir, because you're doing a TVS and that's another advantage that you get.
This concept of discriminatory zone is very interesting. Actually, this was defined by Kader et al. In 1981, and what he meant was that the lowest level at which an intrauterine gestation sac could be seen, and there was a spectrum. Like as the beta HCG rose of intrauterine gestation sac, visibility also increases. So it was a zone, a spectrum rather than a particular level. But a zone really doesn't help. So he actually came to a 90%, 95%, I think, that at 6,500, you would be able to see a gestation sac. But that was by transabdominal ultrasound. But since then, what has happened is because of increase in the or resolution of the machine as such and the switch over from transabdominal to transvaginal, the discriminatory level of this discriminatory threshold has gradually been reduced, and it steadily reduced. And there was an article, I think, by Barnhart or somebody in 1994 where he suggested that at 1500 you should be able to see 80% of the intrauterine pregnancies, and at 2000 you should be able to see 90% of pregnancies, and that somehow stuck on. And most of the books, even Callan and all, also Williams, etc., not obstetric textbook and radiology textbooks, Callan, which is supposed to be the Bible, these two Bibles actually mention this level. And so all gynecology and radiology started following this. Now, what had happened subsequently, it was realized that if we go to that low level and we take decisions around that boundaries of decisions, then what happens is sometimes we can do more harm by actually terminating an inviable intrauterine pregnancy, giving methotrexate or surgical evacuation or even laparoscopy, suspected ectopic pregnancy. And some studies have shown it can go up to 20% or so. So Connolly in 2013 actually did a survey again, and he found out that probably instead of 90%, we should go to the 99th centile. And that he put it as 3,510, which is around 3,500 or so. Now, but still, I think we are not following that. We're still following 1,500 and 2,000. So that's about it. So maybe things will change in near future. Now, what is important for us to understand that why is discriminatory zone important? Discriminatory zone actually does not diagnose an intrauterine pregnancy, or it does not diagnose an ectopic pregnancy, or it even does not diagnose a viability of a pregnancy. What it does, it helps in the outcome or maybe follow-up of a pregnancy of unknown location. That is what is very important.
Yeah.
And then there are lots of
Discuss
algorithms
that
there.
point more in detail later
Sorry.
on.
Sorry. Yeah,
Pregnancy.
yeah.
But I think you brought in a very beautiful point that, okay, 1500 is not like, the ultimate deadline beyond which, you should have something. Because even in this study, which was done as late as 2018, they said that if it is more than 1500, you will be diagnosing 94% of pregnancies. Beyond that, you will still miss. So it's okay. We should have some guidance to that. But yes, I mean, we should not take decisions based on just one thing, and which you have really brought out very well. So, Dr. Sita, now, like what you've been talking about, I think there have been a lot of terminologies, misterminologies, misnomers around this particular first trimester scan, and that really the moment you say those terms, the patients get very anxious. So, what are these, and what is the correct terminology to be used?
So thank you for the question, and again, thank you for moderating this beautiful panel. So it's interesting, isn't it? As soon as we see the cardiac activity, we know that the embryo is there. But when the embryo becomes the fetus, is sort of very loosely hanging there. So everybody has their own definitions. Though the consensus earlier one, I think, was around sort of 9 weeks or 10 weeks. But it's basically that confusion happened because they used to consider as the gestational age, depending on the conception age or ovulation age. But I think now we should the recent recommendations have also said that anything up to 10 plus 6 weeks would be called an embryo, and beyond that we should ideally call it a fetus. And and the various terms that we use in terms when the pregnancy is there is going to be a loss there. I don't think we should be using abortion terms, because that becomes very, it causes a lot of anxiety to the patient, and also there are issues where we don't know exactly what the scientific what has been happening. So I think now again we don't use these terms, even blighted ovum. It's basically whenever we think that the pregnancy is not going in the direction that we want it to go, it would be that it would be a pregnancy loss as such. So early pregnancy loss is what we would consider. And if it's an embryonic loss, it will be an early embryonic demise. Or if there is a fetal demise, it'll be a fetal demise. And we no longer use blighted ovum. Or if there is a sac where there is no embryo in it, then we can call it an anembryonic pregnancy. Or if there is a fetus and there's been no heartbeat, then obviously you can call it an early fetal demise. But everything depends on the time of the time when you scan the patient. And I think such loose terms, especially when, as you rightly put it, that abortion is something that the patient wants to do it voluntarily, so we shouldn't be using these terms. Even insurance people wouldn't accept terms like abortion and stuff, and there's no fault of the patient if you write loosely as an abortion. So that also creates a problem. So these terminology should no longer be used, like blighted ovum or abortion. And typically early pregnancy loss, and depending on whether there is a embryo or not, we can use anembryonic pregnancy as well. Thank you.
Yeah, so it's very correctly said, because something like blighted ovum, the patients really take it very personally, that something really, it's their mistake or something has happened. So
Yeah.
I think we have to be very sensible and sensitive when we are talking about these terminologies. So now we come to the next point, where we have to now start deciding, like, okay, this is the earliest sign of pregnancy. So Dr. Prasanna, would you like to talk about this?
Yes, ma'am. Can you hear me, ma'am?
Yeah.
Yeah. Good evening, ma'am. The earliest sign of pregnancy is the gestational sac. So it is the first sign of early pregnancy on ultrasound, and it can be seen with TVS ultrasound at approximately 4 to 5 weeks of gestation, when the mean sac diameter would be approximately 2 to 3 millimeters in diameter. So that is the earliest sign. There are in the first 4 weeks we don't see anything, but as the gestation progresses, between 4.5 to 5 weeks, we get the possible small gestational sac, and we might also get a double decidual sac sign and an intradecidual sac sign. And by 5.5 weeks at least, the gestational sac should be visible by this time. That is the limit, by 5.5 weeks.
So it's like plus minus 5 weeks, but I think these are the landmarks. So like what you said about the double decidual sign. So, and the intradecidual sign. So, Dr. Arka, can you tell us more about this? And, is it really important? How does it help, or maybe it doesn't help? So, what do you think about it? Has he joined? I could not see him in the.
Yeah, ma'am.
Yeah, he's
Huh?
joined. Yeah.
Okay.
Oh, can you hear me, ma'am?
Yeah, very clear.
Okay. So actually, uh, the interdecidual sign or double decidual sign, they helps us to give an idea whether the gestational sac that is exactly an intrauterine gestational sac or a pseudo sac. So it's try to differentiate between those two. So the interdecidual sign means the sac is eccentrically placed, deviated from the midline endometrial cavity, and there is a ecogenic area just adjacent to the sac. So that's the interdecidual sign, and it gives us an idea that this gestational sac is a proper intrauterine gestational sac. And the double decidual sign is anechoic area between the two ecogenic rim, between the decidual capsularis and the decidual parietalis. So this all gives us the hint that this is the more chance that this is a proper intrauterine pregnancy.
Right. So, do you routinely notice this in your scans, or is it of theoretical value?
Uh, it's only it's not routinely possible in each and every case to find those signs actually.
Right. So yes, of course, when we are in a patient who's very anxious and we are early on in the pregnancy, we're trying to see normally whether it's a good implantation, good decidual reaction. But it has been seen that, it may or may not be of very good diagnostic value. But yes, I mean, these are some things that we should be knowing, have the knowledge about it. And, at least if the patient is coming to us, we can reassure that, okay, I am seeing a sac which is well placed, and it is giving me a good sign that, okay, this is all fine. So, Dr. Ananya, what about the yolk sac? And I think it has a bit of importance, much more than the gestational sac, or maybe. So, what do you think about it, about the yolk sac?
So, ma'am, about the yolk sac, the thing that is of foremost importance is that it is the first surest sign that there is an intrauterine pregnancy. Because when we see a gestational sac, it could be a pseudogestational sac as well. But once we see a yolk sac, we are more or less sure that an intrauterine pregnancy is there. So that is the first surest sign. That is one thing. It should appear by 5 weeks, 5 days of gestation on a TVS when we are seeing it. And also the yolk sac, actually the number of the yolk sacs corresponds to the number of the amnions if it is a polyamniotic pregnancy. So these are some of the significances of the yolk sac.
Okay.
And
do you think that? Yeah, please carry on.
Yeah. So regarding the shapes and the sizes of the yolk sacs, it has been much talked about in the literature. So there have been different variants in the shape and size that has been talked about, like an ecogenic yolk sac, a calcified yolk sac, an irregular looking yolk sac. So a lot of things have been talked about, but most of the studies nowadays say that there is no exact correlation between this and adverse pregnancy outcomes. What most of the studies have seen that there may be a correlation between the size. So some of the studies have said that when it is expected to increase up to 10 weeks of gestation, when it should be 6 millimeter and not more than that. So any yolk sac that is more than 6 millimeter should be followed up for adverse pregnancy outcomes. And there are old studies as old as in 2010. They have even told us that there can be a correlation with preterm delivery later also. But again, some of the studies have completely refuted this. They have told that they have found normal pregnancies jolly well with yolk sacs of more than 8 millimeter. So this size issue is somewhat of a controversy.
Right. So I completely agree with you. You would not take a clinical decision based on the size of the yolk sac. You will wait for pregnancy to progress. But as a general rule, so this article was published in Nature and Scientific Reports, and this was as recent as 2023. And they've looked at, like, so the red one is a normal pregnancy and the blue ones are abnormal pregnancy. So even a larger size and a smaller size are a little bit markers that maybe all is not well with the pregnancy. So just keeping that in mind, I don't doing anything drastic, but just have an idea whether this is going in the right direction or it is not going to the right direction. So I think that's something to be kept in the mind. Now, sir, back to you. So what about the embryonic pole? and how its importance with relation to the G sac and yolk sac. And I think that's something which is the most vital part of our pregnancy. Yolk sac has come, G sac has come, but we are waiting with bated breath for the embryonic pole. So what do you want? What do you think about it?
Yeah, so the first thing is that we will now stop calling it the embryonic pole and we will call it the embryo.
Yeah.
Because there is no pole there. It's an embryo. And we used to use a lot of things until 2011. And then almost all the societies told us that, look, we need definitions which are completely different from what we were using before. So we know that the embryo would be appearing after the yolk sac has appeared, that it is always eccentrically located within the gestational sac, and that usually by the time it appears, it has cardiac activity, but it may not. And so we have definitions to define what is actually happening. So if you have a mean sac diameter of 25 millimeters and it does not show up the yolk sac in embryo, then you know for sure that this is not a good sac. And it's not a good pregnancy. And then if you have an embryo that is 7 millimeters or more without cardiac activity, then that is a non-viable embryo. And so we have dropped all the readings before that, and we don't go by that. We do understand that, yes, those could be markers of a poor prognosis, but these are in the so-called category of soft markers. And you could have perfectly beautiful pregnancies without the mathematics being in place. And therefore, we have to keep an open mind. Also, that these definitions are based on a transvaginal scan and not on a transabdominal scan. And whenever we have a doubt, we must repeat the scan 2 or 1 week later, and no sooner than that, really.
Right, right. So I think very nicely put as the soft markers. Really love the terminology of soft markers in the 4 to 10 week scan. And I think it makes a lot of sense because, yes, these are just markers and you need to keep them on follow up to see how they evolve. And that's very important. And yes, I mean, this thing, as we all know, that if the size is not according to what we really want, so this is growing slower, then it is an indication that maybe all is not well. But then of course we wait and watch. We don't take decisions based on that, but just to know about it. And yes, okay, so what's going to happen next? So the next part, and the most again a crucial part, is fetal activity, heart activity. So Dr. Kushagrati, when do we expect it? Do you measure it? Do you measure the heart rate? Are there any benefits or harm about measuring the fetal activity?
Thank you, Aparna. The discussion is going very well, and I really like the soft marker thing about back prognostic factors of 5 to 10 week scan. But having said that, the proof of the pudding is in its eating, so we have to document a beating fetal heart before we actually can say that the pregnancy is fine. So yes, fetal heart activity is extremely important to be documented. Now, how early? That's the question. Now, with very good resolution scans that we have, we can pick up heartbeat at CRL of 2 millimeter almost as soon as it is visible. 1 millimeter, I'm not so sure, but yes, at 2 millimeters we might. And but yes, over 99.7 or some percentage of fetal hearts should be seen activity by 5 millimeter, but there are cases beyond that, and therefore the limit of 7 millimeter has been kept to be absolutely sure that we are not doing any harm to anybody by clearing an otherwise viable pregnancy. Now, there is an interesting article by Rodriguez, which was published, I think, this year, January or last year, December, which says that instead of writing heart, we should be writing cardiac activity. So, because they said that heart is not yet formed at that point of time, and putting as a heartbeat, things like that puts a little bit of thing that, yes, we have checked the heart is fine. So that is something which can be taken up for discussion later. Now, the next question was, yes, when should we measure? We should measure whenever. We are talking about transvaginal scans. We are not talking about transabdominal scans. 2 millimeter, 5 millimeter, it's 7 millimeter. That's what it is. Beyond 7 millimeter, as Dr. Khurana has already said, we diagnose miscarriage. Now, the question is whether we should document it. Yes, we should document it because, yes, it says about the completeness of the scan. And also it might have some medical legal significance of not documenting. And there are some suggestions that if the fetal heart goes away after it has appeared, then it's probably more like Apla type of thing. And if it appears before the cardiac pulsation appears, more like genetic. So anyway, there is a lot of overlap between them. They are not really clinically important. Now, the benefit is, yes, the patient is very happy, the couple is very happy, the documentation is done. Now, the last question is whether it really can cause harm. Now, the harm is something which is relative. We should be very sure that, yes, we counsel the patient properly, that, yes, we can see some sort of flicker, some sort of rhythm. We can see some undulations, and we have to measure by M mode, not by pulse or color that much, especially for a prolonged duration. And it's not a time that you should start rejoicing and telling your friends and relatives and everybody that you're pregnant. Certainly not post in the Facebook that, yeah, I am pregnant, to be crestfallen later on. So it should be controlled. The euphoria should be controlled. Yes, it should be mentioned. And if there is an upset after that, then it's really very hard to take, very sensitive. So that is one of the harms that can happen.
Yeah, so thank you, sir. And I think all of things you have said beautifully. I think the thing about the fetal cardiac activity is something which is to be kept in mind and which is absolutely all right. Now, this article is a recent one in AJOG in 2020, and they looked at what was the prediction of the pregnancy loss in the first trimester. So they said that if there is a small CRL and a small fetal heart, then the risk is definitely increased beyond the other things. So these are the two very important markers. And yes, the safety measures, like you mentioned, is don't put a Doppler, use an M mode. So I think that's something that we must be doing.
How
And
low is low? How low is low? Is it 90?
yeah,
Or
so
is it?
they have actually made an algorithm, and in which they said that if you have a low fetal heart rate of less than 122 at 6 weeks, 123 at 8 weeks, and 158. But in general, it is felt that if it is less than 110 between 6 to 8 weeks, then it is something which is to be thought about. So the previous articles have talked about it, and this is the most recent article, which is quite categorical. But as a rule of thumb, we feel that if it is less than 110, then it is possibly an indicator of not a very good pregnancy, but then again, a soft marker, and we really love that term now. So we have to wait and watch. I think that's what they
Can I
talk
say
about.
something here? Can I say something?
Yes, please, please.
Like when the fetal heart, when we first see the fetal heart by TVS, generally it is around 80 to 90. And I also want to add my experience here of scanning by TVS, that even before measuring CRLs, we can see fetal heart. That is what I have felt while doing scanning.
Yeah.
That
So
when
you
it
can
first starts, it is very slow, around 80 to 90. And
That's
then
why
it
some of the articles have actually mentioned 90. So
yes.
So
that's a
so I
gray
come
zone.
across
Yes.
100, 110. So, but I thought this is the latest. So maybe that's what it is, So maybe you can, we really have to see. But then again, yes, it's a relative marker that we have to keep in mind and not really convey any anxiety to the patient at the present time. That is what is something which is very, very important. So Dr. Sita, you want to say something?
The other thing we've also seen that, as Prasanna pointed, when reporting, some people do mention fetal, bradycardia. I think that should be avoided in the early part of pregnancy when we know that could be the normal heart rate and cause unnecessary anxiety there. Yeah.
Yeah, absolutely. I completely agree with that. And till we are sure about it, there's no point in really passing on that anxiety to our patients. So yes, again, this is a heart rate which is the blue one is the one where the pregnancies have ended up in an abortion, and they said that okay, this is a slower heart rate has not a very good prognosis. So Dr. Sita, early amnion, to see or not to see, does it have any importance?
So the amnion is the thin membrane that covers the embryo that we see early, and I think it is important to see it because typically the yolk sac is outside the where we see it as a signet ring, and it closely, as you say, it's visible around 6 to 7 weeks. But sometimes if you see, as it's something called an empty amniotic amnion sign, where we see the large amniotic cavity with the yolk sac and there's no embryo there or developing embryo, that could be again a soft marker, now we call it, of impending problems or adverse outcome to that pregnancy. We must remember that as the gestational age increases, the amniotic size increases, and eventually it fuses with the chorion, and that happens only around 15 to 16 weeks. So you shouldn't be, in a rush to call it a sort of an abnormal sort of separation or something before that time, and again cause anxiety. So it is important to look for it. It doesn't have, we don't sort of clinically sort of give it that sort of any sort of interpretation there, but it is important to look for it and see what else can we see with it, along with the chorion.
Yeah, so yes, I think that's something. So very nicely put. So this is something that we see, and sometimes we feel that it has not fused with the chorion, and there is the floating membrane that we see, and we are quite worried about it. But like you said, the fusion happens around 14 to 16 weeks, so we should not worry about it. And interestingly, it has the size of the amniotic sac actually corresponds to the length of the CRL, and if in a normal pregnancy. So this is something that is there, and if it is excessively enlarged or a very big amniotic cavity, that is something that is again a very soft kind of a sign, and that we might want to look at. So this is all for the purpose of knowing things, but then again it is to be seen as a finding, and then correlate with how the pregnancy is going on in the first trimester. Now, Dr. Prasanna, sonoembryology, do you routinely do it? What do you want to see in it? What would be your objectives of doing it? So I think the prerequisite for sonoembryology is to have a very good machine, and also a very good, the man behind the machine or the woman behind the machine, I think, because that's something which is extremely important. You have to be really committed and dedicated to be doing this sonoembryology. But what is your opinion on it, and how much do you do, or how much is it needed?
Thank you, ma'am. So we do it regularly in each and every case. And sonoembryology, basically, we all
That's
know
why I
it was
put that
first.
question to you.
Okay, so first, it was first developed back in 1990s, as early as 1990s by Trish, and it's an organ-oriented approach which will use, as you said, high frequency TVS probe, and the machine will matter the most here, because just by 2D it will really not be possible. We have to use higher end techniques like 3D and use HD Live and Silhouette applications to actually make out the development of the embryo or the fetus, because it can be used to study the normal development of the embryo or the fetus, or we can identify congenital abnormalities also at below the 10 weeks of gestation, because no matter how much the genetics and the sequencing techniques they improve, the fetal ultrasound is the only technology which has a direct observation of fetal structures and function from the early gestational age.
Yeah. So I
And
think Dr. Prasanna
doing a
really,
3D is a basic
yeah.
requirement for this.
Yeah. So I'm sure it does take a lot of effort and knowledge of sonoembryology. And
Yeah.
I think, yes, we really need to look into it and see that within the 6 to 6+6, what are we seeing? And I think by 7 to 7 weeks and 6 days, there's a lot of development of the rhombencephalon, which is visible as a
Yes.
diamond-shaped structure. And then amniotic cavity and is already seen within it, which the embryo is there. In the 7 weeks, of course, you can also see the fetal head,
We
which
can
has
see
now
the
very
spine. We
large.
can make out the
And the
vertebral bony
spine,
structure.
yes. Yeah.
Yeah, we
So
can make out the embryonic circulation by 3D power Doppler. We can use the maximum mode for the bony structures. We can easily make out the spine and predict acranias and encephaloceles in during the 8 to 10 weeks of gestation. And we can also do a detailed brain morphology by 3D inversion techniques and TUI, and so that we can also predict holoprosencephalies during 10 weeks of ultrasound if the telencephalons are not developed. So knowing the brain morphology also will be important when we are doing this 3D. And we
right.
do it regularly. We take a 3D of all the fetuses which we do, and we have learned this to diagnose congenital abnormalities like encephalocele or neural tube defects or acranias by doing retrograde studies, because initially when we used to do, we did not diagnose them, but since our 3D volume was there in the machine, when during NT scan when we found them, and then when we went back and looked at our viability scan images of the 3D, then we understood that how we missed it. So now we regularly do a 3D and store it, and then match it when we do an NT scan again.
Right. So I think this is a great approach that you're talking about. I think this is something that is yes, very special, and it's called, I would say, Dr. Prasanna, it's like pushing the boundaries now, and really trying to correlate and going beyond what is normally to be done. And honestly speaking, I have recently started doing this sonoembryology, and I have started doing it, but I do think it does require a lot of time and effort. So that's something that to be kept
If
in
we
mind.
do, if we are in a habit of doing a proper 3D, it will hardly take seconds, ma'am. It will hardly, and do a proper multiplanar imaging, it will be done in few seconds.
Yeah. So, Dr. Arko, what about mid-gut herniation, and when do you call it as pathological? So, what is the limit, and how do you say?
Well, during the 7 to 12 weeks, the due to the more development of the midgut, it herniates outside the abdominal cavity, and if it persists beyond 12 weeks, then we'll call it pathological. Otherwise, we just, even if there is a large defect in the anterior abdominal wall, we just follow it up till 12 weeks. If it doesn't come back to intra-abdominal till 12 weeks, then we call it pathological.
Yeah, so very correct. And I think between 7 to 12 weeks, like you said, it is happening. And it returns because of the growth of the body or decrease in the mesentery length. And there are some features which can differentiate from between the omphalocele and midgut herniation. And of these, they say that if the measurement is larger than 7 mm, it is more likely to be omphalocele. If, however, it is between 4 to 7 mm, it is more like a midgut herniation. But yes, absolutely. But what we completely have to agree is that beyond 12 weeks, it is abnormal. And if it is persisting, then we have to start thinking about omphalocele. So, Dr. Ananya, what about the heart? Are you looking at the heart? Is it possible? What are the limitations?
So, if we talk about heart, beyond the heart rate abnormalities that we have already discussed about, so there are studies that case reports, like one was published by Rolnik et al. They have published a case series along with a study of this in EOG in the year 2019, and they have given a few case reports of the hypoplastic left heart syndrome cases that they have picked up between 8 to 10 weeks of gestation. So they are saying that at least 52% of the patients should show up the fourth chamber view of the heart around 8 weeks, and around 80% will show up at least a clear fourth chamber view of the heart, that is by 10 weeks of gestation. Also, they are saying that sometimes by 10 weeks of gestation, the outflows of the heart should also be visible. Uh, so, so that is what the body of evidence is telling us, that we should try to look beyond heart rate abnormalities. We should see the location of the heart, and we should try to delineate the outflows and fourth chamber view at least 9 to 10 weeks of gestation scans, or 9 to 10 weeks of gestation.
Yeah, so I think this is something which is extremely important to know that, and actually, like you said, this is the only article which automatically looked into what is possible before 10 or before 11 weeks of gestation by this article by Rolnik et al. And they have really looked into the possible abnormalities that can be detected. So there are a limited few, but yes, if this is something, if you start doing routinely, probably you'll pick up more of these problems. So now we move on
We
to the
should be
next.
doing it only when we suspect something, right, ma'am? Not
Yeah.
routine color or power Doppler used during
Yes,
this.
So just take a 3D, and we can probably look into it later. But these are some things, again, we talk about which is less commonly done, but at least we should have the knowledge of these things. So Dr. Khurana sir, coming back to the ground and to the more basic things, that there are certain things like the chorionic bump, umbilical cord cyst, ecogenic coelomic fluid, which look very sinister. So what is your idea about it? And how are you going to tell your patients or counsel that, okay, this is normal, this is abnormal?
Certainly. Are you able to hear me?
Yeah,
Yes,
absolutely.
yes.
Yeah, okay. So there are the chorionic bump essentially is a hematoma. It's an early hematoma, therefore it is echogenic, and therefore it would have the outcome of any other hematoma, which means that most hematomas would resolve.
Yeah.
And therefore it's really not very important, and we don't get alarmed. And it appears very dramatic, but just like all other hematomas, it becomes hypoechoic and goes away. Yes, if it's close to a future placental site, there might be a problem, but that's not the usual. The second situation that we find is that of umbilical cord cysts. And we know that first trimester umbilical cord cysts are not really a problem and are very rarely associated with the problem. We used to believe that those at the fetal end might be more important, but that has not stood the test of time. And now we know that most umbilical cord cysts will go away. The only reason why I would ever attach importance to an umbilical cord cyst is if I found an umbilical cord cyst and a dysmorphic dead embryo, in which situation I would say, okay, these products might do well with a genetic analysis and therefore might prognosticate that patient for future reproductive outcomes. So if I found a combination, I would give importance to it, not otherwise at all. And therefore, when we know that these things might actually be there or not there, the one that is still a bit of doubt is the echogenic coelomic fluid, and there is possibly that this is a consequence of previous hemorrhage, but again, this is not known to be associated with a higher risk of miscarriage. So really speaking, these three are not important findings.
Right, sir. And I think ecogenic fluid we also see later on in the pregnancy, sometimes in the second and third trimester, but we
True.
really have to kind of ignore it and, move on and look at the other things. So thank you, sir. And
Yeah.
I think it's a very important message that we need to give, because we do get a lot of anxiety around it and a lot of reporting, and then, things just can be very, very stressful for the patients. So now we
To
come to
ask
the
sir a question, sir. So, do you think these recent newer probes give a false impression of, in some cases, a false impression of subchorionic hematomas beside the gestational sac? The patient is not
Well,
bleeding; there is no symptoms, but there is a hematoma-like feature on ultrasound.
that's right. Most of these are actually unobliterated uterine cavity, and there is no doubt that we should not attach importance to them. Anyway, we understand that most subchorionic hemorrhages will not be directly responsible for a miscarriage, that the hematoma is a consequence of the miscarriage and not the cause. And that
Right.
is why we don't touch them anymore. Once upon a time in Sweden, we were emptying them out. And now we realize that's of no consequence. So it's not that they are causative at all. So we don't attach importance to the size or the presence of a hematoma.
Right.
Yeah.
Right. I think, yeah, there's a lot of discussion around hematomas, and unless the patient is symptomatic, mostly they do, subside, and they do
Yes.
not affect pregnancy. Very true. So now this, we come to, sir has already talked about, the absolute criteria for abortions, but this was a patient who came to me a few days back. She had a previous MTP, very anxious couple at 8 weeks and 6 days. In this pregnancy, a previous scan was done 1 week back where the CRL was 2.7. So will you call it miscarriage? So 1 week after that, the CRL has not increased. So, let's, without, so to sort that confusion out, let us now go step by step. And sir has talked about the two definite criteria for miscarriage. But Dr. Kushagriti, can we talk about the definitive diagnosis of miscarriage, and when we can say for sure that, okay, this is not going to go on further?
Well, this is a very important topic, and this is probably the most important issue that centers around early pregnancy scan, whether the pregnancy is viable, whatever, or not. Now, the definite criteria would be of a miscarriage would be mean sac diameter taken properly of 25 millimeter or more, with no embryo or yolk sac, or when the CRL, if it is visible, we should measure it 7 millimeter or more without any demonstrable cardiac activity. These are one-off criteria. Now, when there are around the decision borderline zones, then we should always follow up. And the follow-up, if we follow up after 14 days, and if we still so now, if there is no embryo with a cardiac activity 14 days or more after the initial scan, which had shown no yolk sac, then we diagnose miscarriage. And if there is no embryo with a fetal heart more than equal to 11 days after a previous scan, which had shown gestation sac with a yolk sac, then we call it a miscarriage. So those are the four definite criteria: two one-off
Right.
and two follow-ups.
Yes, so I think very nicely said. And so basically, when we talk about this, that we refer to this article, which talked about this was the NEJM article, and most of our references are coming from there, where the diagnostic criteria, like you mentioned, for non-viable pregnancy early in the first trimester. So, like you said, CRL of more than 7 with no heartbeat. The corresponding suspicious of pregnancy failure would be CRL of less than 7 with no heartbeat. The diameter of more than 25 with no embryo. Mean sac diameter of 16 to 24 with no embryo is suspicious and we wait. Absence of embryo with a heartbeat more than 2 weeks, like you said, after 14 days. So if you have an embryo with a heartbeat more than with 2 weeks after gestational sac without a yolk sac, and if it is more than a week but less than 2 weeks, it is suspicious. And absence of embryo with a fetal heartbeat more than 11 days after gestational sac with a yolk sac. So, and similarly, if the corresponding suspicious finding would be that if it is between 7 to 10 days after a gestational sac with a yolk sac. I think this table is something that can help us remember and make a definite diagnosis of abortion or sorry, of a miscarriage or no miscarriage. So this was the article which gave, but a little going back. So when we talk about the other suspicious findings that we have been talking about, so Dr. Sita, would you like to mention any other factors that we have been discussing till now, which can tentatively predict miscarriage?
Yeah, so firstly, whatever it is, we'll have to take a history. So any history of spotting or, altered blood that she gives history of passing or pain, even for that matter, will be first an indication that there is some problem going on. And then when you insert your transvaginal probe and see these findings, if the sac is irregular, first of all, with irregular margins, that could be a sign that, there is a problem. If the yolk sac is very large, normally it would be 6 millimeters if it's large, though they're not as Khurana sir said, these will be called the soft markers. And then if there is calcified, well, that is one thing that we look at, the large amniotic, empty amnion sign. And that, as I said earlier, where there is no embryo, but the yolk sac is seen, but the embryo is not formed yet. Or if there are signs of any bleeding out in the, subchorionic bleed, that could be there. But most of the time, if it's not more than 50%, that the pregnancy would go on. So these are all telltale signs where we could follow them up. And as you've put on the criteria, they are all definitive of diagnosis. They're only suggestive, but all the definitions would be based on the measurements, as you've put about 7 and 25. So that would be there. Yes, bradycardia to some extent, even at around 10 weeks, if there is still less than 110, we would consider as all these telltale signs. And yes, we need to follow them up, not make the patient anxious, and give them the benefit of doubt.
So thank you for putting all of that together. So I think this is important that we remember this table, that these are the definitive signs of diagnostic, only 4 signs, and then maybe in the rest of the time we can probably wait and watch. So I don't know if it's very visible, but this table is very, very explanatory in the sense that if we have an intrauterine gestation and there is a fetal pole, and if the CRL is more than 7, if it is more than 7 and no cardiac activity, then of course this would be a miscarriage. But if it is less than 7, then we repeat the scan. If it is an intrauterine gestation without a fetal pole, is the mean sac diameter more than 25? If it is more than 25, then it is a miscarriage. If it is yolk sac is present, then in that case, repeat sonography in 7 to 10 days and then consider. If it is without a fetal pole and the MSD is less than 25, then you repeat sonography in 7 to 10 days. And then then also there is no difference, so it becomes an miscarriage. So I think this table again gives us a good idea on a stepwise approach on how to make a diagnosis and not jump to the problems too early. So Prasanna, what about, so this was about a miscarriage, and like Dr. Kushagra said, I think this is the most important part of the first trimester viability scan. We move on to the next section, which is about the number and the chorionicity. So how do you go about it, and are there any pitfalls in practice, and what are the key points that you would like to look for?
Basically, like determination of chorionicity, there are two big thumb rules we all know. That is the number of gestational sacs equals to chorionicity, and the number of yolk sacs equals to amnionicity. Now this holds true for the chorionicity, but not completely true for the amnionicity part, because the when we consider chorionicity, that is before 10 weeks we are talking about here. So a single when there is a single gestational sac containing two live fetuses, it is indicative of monochorionic twins. Whereas if there are two distinct separate gestational sacs, each having a separate live fetal pole, it will suggest a dichorionic twin. And this number of yolk sacs equals to number in equals to the amnionicity of the pregnancy. That means that one yolk sac is monoamniotic twin and two indicates diamniotic twins. But this is completely not true, because in 85% of cases of diamniotic pregnancies, they will have two yolk sacs in the early pregnancy. That is true, but 15% will have only one yolk sac. And even in monoamniotic pregnancies, conversely, there might be two yolk sacs during the early pregnancy. So it is not completely true that the number of yolk sacs equals to n. But these are thumb rules, basically, what we need to understand. And there are how do we diagnose it? We diagnose it by during the early scan. We diagnosing chorionicity is easy. That is, we just see the number of sacs. And if we want to diagnose amnionicity, then we follow the black lambda and white lambda sign. We do not follow the T sign and the lambda sign, because you do not get T sign in this in the first trimester, especially with these newer machines. And when we are doing a TVS, we will not get a T sign. Rather, we will get a lambda sign, but the lambda will be black. If black means empty, when there will be no chorion leve entering into between the amnions, and white lambda means there is intervening chorion between two amnions. So white lambda and black lambda, that is how we differentiate monochorionic and dichorionic pregnancies during this early pregnancy scans.
Right. So thank you, Dr. Prasanna. And I think this is, I just wanted to bring this to the notice that this has just come in January 2025. And like you suggested, it is important that, you know, nothing is absolute. Sometimes you feel, but the chronicity should be determined definitely prior to 13 weeks. And it should be based on as many signs as possible. And why
Yes.
are we saying that? Like what you're saying is, important because intertwined septum, it may be at the sign of insertion, it is thick, but sometimes, you know, as you move along, it becomes a little thinner. So not
So
to
that is why
create.
we need to examine the septum from the origin to the bottom,
Yes.
top, for the entire septum.
Yes, so that is extremely important, because now increasingly we realize that it's not just, you know, monochorionic and dichorionic are not just black and white. There are some grays,
Yes.
because we know
Yes.
that, you know, there could be number of placental masses could be 2, but it could be also, you know, dichorionic may be fused, or 3% of monochorionic could have 2 placental masses. So earliest gestation is the best time to also possibly see, and 5% of the monochorionic twins can be dizygotic. So we have to really look into all the features and also save the images for, you know, later consultation. And I think that's something which is extremely, extremely important, that we save those images so that we can look into it if we want.
Last week it happened, ma'am. We had a case of monochorionic diamniotic pregnancies, but when we went and scanned again during the NT scan, we were seeing 2 placentas, and we are not really sure about the ITM also. But then when we rechecked our viability scan images, we were sure that it was a black lambda.
Right, right.
So
So
there can be 2 placentas in monochorionic pregnancies also, that is bipartite ones.
yes, and I think people who are doing this scan have this responsibility to document it absolutely correctly, because later on there is so much of confusion regarding this that even, you know, a previously documented dichorionic presenting as with features of
Yes.
TTTS. So we regularly face these problems. So I think it's a responsibility of people doing the scan at this gestation to save those images so that they can be referred to later. Now, some basic things, Ananya, Dr. Ananya, can you talk about, because the measurement principles become very important. So how do you go about, you know, measuring the gestational sac, yolk sac, and the CRL? Some basic principles about measurement.
So when we are measuring the gestational sac, we are taking 3 orthogonal planes, and then we are getting a mean value for that, the mean sac diameter. And we are doing that, but we are not assigning EDD on the basis of that. We are not assigning the gestational age based on that. This about non-IVF pregnancies. For IVF pregnancies, definitely it is by the date of conception. Second, if we come to the yolk sac, we have to measure from inner.
I am. Yeah, sorry. Am I logged out or
No,
she was logged out? Okay, I thought I'm logged out. Okay, just
No,
I'll
no,
share.
you are there. You are there, ma'am.
Okay, okay. Yeah, so I think Ananya will join soon. So we just want to say that it has to be from the inner to inner measurement of yolk sac. Yeah, Ananya.
We also should know. Yes.
Yeah.
Ananya, maybe you can switch off your video and talk. Because if your network is poor. Yeah. Carry on.
Am I audible?
Yeah,
Yes,
yeah.
yes.
Am I audible?
Yeah, yeah. Ananya, you are.
Yes. So I was talking about CRL. So ISWAG has given us clear-cut guidelines about the measurement of CRL, but ideal CRL measurement when the fetus is to hyperflex before 8 weeks of gestation is not possible. So then we take the greatest dimension of the fetus, whatever we are seeing. But between 8 to 14 weeks of gestation, we can actually correctly measure the CRL, excluding the yolk sac, according to the ISWAG guidelines, and accordingly we can assign the gestational age.
Right. So I think this is very important that, and that's why they say that, just gestational age measurement is extremely important and we should not assign before 8 to 9 weeks of gestation because as you said, the embryo is flexed. So measurement is extremely important of these parameters. Now we come to some clinical questions. And commonly faced scenarios. So Kurana sir, this lady is a primi gravida, her pregnancy test is positive and she's very happy and she's come for a 7-week scan, but you don't see any gestational sac. So what will you think and what will you do?
So start with the background first, and we know 7 weeks period of gestation. That does not mean I expect to see a 7 weeks intrauterine pregnancy always. And so I'd like to know what the HCG levels are like and see whether they are beyond the famous discriminatory zone, and then expect to look for it. If it is above the discriminatory zone, I think the next thing I want to see is, do I see an extrauterine pregnancy? And if I don't see a extrauterine pregnancy, then it would become a pregnancy of unknown location. And
Right.
then I would correlate it with the so-called doubling of HCG. We know that HCG does not double in 48 hours. It actually doubles a little before that. And therefore, we must take that into mind. And then we would then decide whether it's a failing pregnancy of unknown location. And otherwise, I should expect to find an intrauterine pregnancy.
Right. So I think that what you said is that very important, like you mentioned, that beta HCG doesn't double. It is increased by 66%, but it has also been seen that if you actually take a bigger data, so only 53%, at least 53% increase should be there. So we should not be expecting too much from the embryo at this point in time and put too much of performance pressure on it. I think even if it is increasing by 53% at this particular gestation, it has been seen that the pregnancies have been all right. So like you said, I think serial beta HCG would be possibly done in this pregnancy if you don't see. And there is another concept of an HCG ratio where they talk about HCG at 48 hours divided by HCG at 0 levels. And we know that if the ratio is more than 1.6, that means the rise has been good, then the outcome is likely to be an intrauterine pregnancy. So sir, now this patient had a beta HCG rise by 50%. So she's come to you after 2 days and her beta HCG rise is now maybe after 1 week she has come and the rise is by 50%. So what will you do next? And you obviously
So, I would like to confirm whether it was done in the same lab, because there could be laboratory differences. If it was done in the same lab, they probably use the same kit and it becomes comparable. And then I really start getting nervous on whether I'm missing an extrauterine pregnancy. And I would then look again very carefully, including a transabdominal scan, because you never know where it might actually be located. I'd also then make sure that I'm looking at the cervix, the cesarean scar, any accessory horn and so on, and not miss an extrauterine pregnancy. And then give a guarded prognosis, and then again wait for another 48 hours.
Yeah. So I think that's absolutely correct, sir. I think what you're saying is that, okay, let's not just jump the gun. We have to wait. The beta HCG, you wanted us, we want the beta HCG to rise by 66%, but it has risen, but not to 66%, and it has not fallen down. So we are like in the middle, but you still can't see an adnexal mass, no intrauterine GSAC. So possibly we are looking at pregnancy of unknown location. And yes, we possibly, people would jump and say, oh my God, do we need to do something about it? And should we be, really treating this? But I think that's again something that we have to see. And what sir said is probably you would want to see it again after 2 days and wait. And as we discussed, beta HCGs less than the discriminatory zone will not really rupture and cause too much of a problem. So I think that is something that we have to see. What are we doing, and are we really worried about, and start giving methotrexate. Having said that, there have been some studies where they say that if the beta HCG is rising but not up to that level. So there was this interesting trial which was published in JAMA in 2021, the ACT or not randomized control trial, where when they looked at the 2 consecutive beta HCGs rise, which was less than 15% per day, that is less than 30% in 2 days and 50% in 3 days, and they basically followed it up at least up to 7 days. And then if they thought that, okay, this is not going to happen, and the exclusion was a beta HCG which was more than 5,000. So if the beta HCG is very high, then of course, then we have to not be sitting on it. But before that, you have waited enough and you still think that, okay, there is nowhere I'm going to find this pregnancy. In that case, we can possibly, in a guarded manner, give methotrexate, because that has seen to have frequent, quicker resolution of beta HCG. So I think that is something for pregnancy of unknown location. But the key is wait, and let's not jump to give methotrexate. It has been reported that more than 40% of the methotrexate which has been given for PUL may or may not have been needed. So I think that's something that we have to keep in mind when we are managing pregnancy of unknown location. So coming to the next case. So this is this lady who has 7 weeks of pregnancy, mild tenderness all over the pain abdomen, and mild tenderness, cervix, vagina, and healthy. Uterus is normal size, but there is fornicial tenderness. So we find these are the findings. Here you can see some free fluid with the clots. The cavity seems empty, and this is the finding. And I don't think we like to see this at this particular point in time. So yes, so Dr. Kushagrati, not a happy situation. So how do you?
Well, this is basically an extrauterine pregnancy, because you see, it showed the uterus and it's empty, both the uterine cavity, endometrial cavity, and the cervical cavity, endocervical cavity, and there is free fluid. In all probability, this would be blood. And when you say pregnant, I suppose the pregnancy test, during pregnancy test, is positive, or some beta HCG was done and it was higher than 50 or so. Now here what we see is a ring-like structure, which is a hyperechogenic rim with a somnolucent area in between, and there is free fluid around the gestation sac. And on the left-hand side, we see a fetal heartbeat. Now, if there is a fetal heartbeat, all probability this has not ruptured. This is probably a leaking ectopic pregnancy. Blood is coming out of the fimbrial end of the tube, or maybe the pregnancy is in the process of expulsion. Now, whatever it is, because there is free fluid and the fetal cardiac activity, there's no question of expectant management, even if the patient is hemodynamically stable. The other one is conservative management with methotrexate, but then we know that with fetal heartbeat positive, that is a contraindication for giving methotrexate. So those two are out of question. So now it comes to surgical. Now, surgical laparotomy and laparoscopy. In all probability, this patient is hemodynamically stable and should be referred to a center which has laparoscopic facility, because it would be really bad for her to undergo laparotomy to clear this pregnancy. So in laparoscopy, again, we have 2 options. One is to go for salpingectomy, and the other one is to go for salpingostomy. Now, in this patient, he already has 1 child, because I think you said
Yeah.
G2
It's
para 1.
parameter.
So then we have to counsel her that yes, probably we would like to remove the tube, and I will come to the questions later why, and put it in a bag and take it out to the trocar. Now that actually does away with the increased chance of ectopic on that side. But if, for example, she wants to preserve the tube, then we have to do a salpingostomy, a linear cut on the bulging portion of the tube, cauterize it to make it bleed free, take out the gestation sac by irrigation, and then taking it out is challenging because this gestation sac is exposed, and we have to be extremely careful not to spill it anywhere inside the abdomen. And putting into a bag is one option. The other one is to use a method which is called intratrocar expulsion, taking out. So that I'm not going to describe now because it's beyond the question, beyond the scope of this here.
Yeah.
So by that, what I mean is we have to be absolutely sure that we gestation sac. Now there are some reports which suggest that after this sort of operation, salpingostomy, taking out the gestation sac, you should follow it up with beta ECG.
Right.
But majority of the doctors actually don't follow this, and that you need to do a transvaginal scan again, which is usually not followed. And so this is the end of the story basically. But we have to counsel the patient very well that there is and even sometimes milking of that ectopic pregnancy can be done in this situation. Now, all these things can actually increase the chance of repeat ectopic pregnancy on that side. That has to be counseled. And even if the pregnancy doesn't happen, there is a possibility that actually the tube is blocked already because of this blood and fibrosis and later on. So all these things should be explained and salpingostomy can be done.
Right, sir. So I think that was quite comprehensively expressed. Like what we saw here was a live ectopic pregnancy. However, just to skip through the other findings, there could be an inhomogeneous mass which you are seeing in the adnexa, or there could be an empty G sac without the fetal pole. And then, of course, you can have the yolk sac with the fetal pole. So these are the other various findings that you can find in the ectopic pregnancy, which is the more classical findings. So, Prasanna, sir, we have now finished almost 1 hour. I think we can take another 10 minutes to complete the scenarios.
Yeah, I think so.
Certainly.
Yeah. So now, Prasanna, can you tell us more about, so this is the classical ectopic is quite clear, and then it's outside and the uterus is free. But what about these interstitial, angular, cornual pregnancies? What is these are overlapping terminology. So what do they actually?
Yes, ma'am. So an interstitial, basically this angular and cornual pregnancies, these terms are to be avoided nowadays. Everything is either intrauterine or extrauterine, but ectopic can be both. It can be intrauterine. Previously, it was told that any sac lying outside uterine cavity is known as pregnancy, but they did not consider the cesarean scar ectopics or a cervical ectopics or an interstitial ones. So an interstitial it's a rare type of ectopic pregnancy, and the pregnancy will implant within the intramyometrial segment of the fallopian tube. Now, what will happen? There will be an absence of this sliding sign. There will be no sliding sign between the uterus and the GS, that is the gestational sac. Normally in tubal ectopics, we can make them move separately by the TVS probe, but here we can't. And when we do a 3D and we on coronal C-plane images, we can make out that it is in one of the either in the right or the left corners of the uterus. So to differentiate, basically these angular pregnancies were what we used to call previously angular pregnancies, where the implantation they occurred eccentrically along the fundus of the endometrial cavity, along the lateral upper angle or the cornu of the uterus. But now these terms are not to be used like cornual pregnancy. Like cornual pregnancy nowadays, we refer to a pregnancy in one of the cornus of a bicornuate uterus, or maybe in one of the horns of a septate uterus. So angular, cornual, these terms are not to be used. These are all intrauterine pregnancies. Only interstitial pregnancy, it's a ectopic type of ectopic pregnancy, and we need to look for the interstitial line sign, which is difficult to demonstrate, but on 3D on coronal plane images, we can make out the interstitial line sign in some of them, and there will be a partial thin rim of myometrium which will be surrounding the gestational sac. But it's an emergency. We need to inform the obstetrician especially if it is bulging outside, the myometrium is deficient on the outside part. There is a high chance of rupture, and these are very vascular areas. Just like in tubal rupture, the patient might be stable, but in cornual ruptures, these interstitial ones, the patient will directly go into shock.
Yes. So like you've very nicely said, I think this is the thing, and we should avoid any other terminology. We should call it the interstitial pregnancy. And we can see that when we are going through the center of the cavity, you cannot see a sac, but when you go to one side of the cavity, you can see the sac on one side. So I think these are a little tricky, and even more difficult to manage because, the bleeding and everything. So yes, it is a challenging and kind of an emergency. So
doing 3D in this first trimester, it will help us to diagnose interstitial ones. But
Yes.
just looking at the sac won't make us realize that where it is located. But if we take a 3D and run a sweep, we will certainly feel that it is outside the endometrial cavity.
Absolutely. And I think this is one of the important uses that we can really make a diagnosis. So, Dr. Sita, just a quick word about heterotopic pregnancy. Is it common? Is it uncommon? And when should you kind of, suspect it?
Thank you. So, just I would like to comment on, when we talk about ectopic pregnancies, the term pseudo-sac also should not be used because that gives even if it's not an ectopic, then unless when we put that in the picture and then people tend to think it might be an ectopic when it might not be. So just something like fluid. Okay. So in heterotopic pregnancies, basically when there is an intrauterine as well as an extrauterine pregnancy, it's not very uncommon, especially with the use of ART pregnancies. The incidence in spontaneous is about 1 in 30,000, but with ART, we can say it is around 1 in 1,000 pregnancies. And of course, it is difficult because, there is an intrauterine pregnancy as well. So the clinical suspicion needs to be really high because the patient might not be symptomatic, or even if she's symptomatic, if we see the intrauterine pregnancy, our entire focus goes on to that and we tend to miss. So we need, but you have to take into consideration risk factors, that especially if she's had ART, if she's had a tubal surgery, previous endometriosis or sort of things, or previous ectopic as well. So these would be high risk where you would additionally look for an heterotopic pregnancy. And once you see an intrauterine pregnancy, you always, as a matter of rule, you would look at the adnexa generally also. So in this case, if you find any adnexal mass there, which looks like an ectopic pregnancy, we need to be suspicious of heterotopic. And yes, we need to diagnose, we need to differentiate it from a corpus luteum, because you will see the thick hyperechoic rim in the ectopic, whereas in the corpus luteum, because both will have vascularity and you might confuse it, and there might be tenderness with both. But yes, that should be the high risk of suspicion. And yes, you can't use beta HCG because there is always there is an intrauterine pregnancy. So management will be depending on that, how stable she is, and if methotrexate might not be, obviously systemic will not be useful here. Either you can use KCL to aspirate, or for the heterotopic pregnancy, for the ectopic, or if it is required, if the patient is clinically unstable, you might go in for a surgical management, but to make sure that you don't do any uterine manipulation, not to disrupt the normal intrauterine pregnancy that's going on.
Yeah. So I think the key is, like you said, is we need to suspect and look at the adnexa, even if we have a normal intrauterine pregnancy, especially in cases of IVF and assisted reproduction. So you cannot just rule out, and this is becoming increasingly common with the use of assisted reproduction. So just coming to the next case, which is bleeding PV. She had amenorrhea for 2 months. Her beta HCG was 9,800, and this was the image that was scanned when this came, and this is the cervix, and we can see that there's a little bit of a lower implantation, and it could be seen on 3D as well. So Dr. Ananya, what is the thing, because we see scar ectopic more and more, so why are we seeing that, and how do you make a definitive diagnosis? And just while you're at it, I would like just to know that low implantation of a gestational sac, and I think that is something which is extremely important to understand and make a note of. Ananya, are you there? Yeah.
Yes, ma'am. Yes. So, scarred ectopic, essentially we have to look into the history of the patient. So patients who have a preceding patients. So when we make a diagnosis, am I audible?
Yeah, you're breaking. Your voice is breaking, but you're audible. Maybe just switch off the video. Maybe the network will improve. Yeah. You need to unmute.
Yeah. So, so in this case, what we have to see is that essentially there will be an empty uterine cavity, and when we are looking at the scar site, we will find that the gestational sac is. Hello.
Yes.
Yeah.
Yes, Ananya, you're
The
audible.
gestational sac will be around the area of the scar, so it will be much low down. It will be much low down in the lower segment. Yes, so it will be much low down. I'll be able to see increased vascularity around the G-sac, and it will be located much low down at around the level of the previous scar where it is expected to be. So that is how we make a diagnosis. So the uterine cavity, endometrial cavity will be empty, and there will be a low down position near the lower uterine segment at the site of the previous scar, which is on the color Doppler.
Right. So like in this particular case, we see that this is a low-lying position of the sac. So just to put in across two markers that we talk about, it is the above the line and below the line. Here we draw a vertical line in the middle of the uterine cavity and through a line which is passing through the sagittal plane. And if our sac is above the line, then it is the safer implantation. But if it is below the line, it is more likely to progress to scar ectopics and placenta accretas. And then we, of course, have the cos sign in which a line is drawn, straight longitudinal line is drawn, connecting the internal os to the fundus of the uterus. And if the sac is above the line, then it is the SI, superior inferior line, is above this particular line, then it is a safer implantation and lesser chances of placenta accreta. But if it is below the line, then it is more likely to be a scar ectopic and a placenta accreta. So I think if we just have this lookout that if it is a lower implantation scar or a lower implantation gestational sac, then all of this predisposed to this particular entity. So in this patient, she underwent a transvaginal guided aspiration of the sac, and methotrexate was injected into the sac, and half was given as IM. Post-procedure, because of the vascularity that was seen, the bleeding PV continued and she was taken up for UAE, following which she subsided. So here we can see the sac, but post-procedure, the content of the sac was aspirated, following which a UAE was done, and this patient's beta HCG came to the negative value. So we regularly see a lot of cases of scar ectopic, which we have managed over the years, and isthmocele is something which is again predisposing. So just to talk in a brief, the last case, Dr. Arka, is this particular finding. Could you just talk about it? So this patient presented with some bleeding and some passage of vesicles.
That's the snowstorm appearance we see through the transvaginal scan, and which will lead to the diagnosis of the hydatidiform mole. The high beta HCG level, along with the passage of vesicle-like structures and such ultrasonographic findings, that will give the diagnosis of H mole basically.
Yeah. So would you like to talk about a bit about, like, how do you differentiate this from the partial mole, partial versus complete mole? How do you like really guide your diagnosis on it?
In case of partial mole, there some fetal parts should be visible through the ultrasonography, but in complete mole, the entire picture will be the entire picture will the entire screen will be like the snowstorm appearance. No particularly no fetal part can be visible, and if some part of the placenta can have some changes like hydropic changes, then we can give the diagnosis of partial mole also.
Yeah. So I think it is surprising that we keep missing the diagnosis of even a complete molar pregnancy in up to 50% of the cases sometimes. And it's sometimes a histopathological diagnosis, and partial mole is even more missed in up to 10 to 90% of the cases. And there have been certain signs which have been suggested that if there is some cystic changes in the placenta, or a significant cystic changes in the placenta, is more like a partial mole. And like you said, you can see a yolk sac, you can see a fetal pole, and the beta HCG, of course. And it is one very peculiar thing about a partial mole is that the transverse diameter is more than the vertical, which has been repeatedly reported. And I think some of the things that we should keep in mind about the partial mole. So I think there is so much more to cover, but we can only do so much, and we've already exceeded so much time. So I would like to really conclude and then take comments from our list that 5 to 10 week scan is an important scan to prognosticate the pregnancy. Knowledge of normal development helps in assessment of pregnancy outcomes. Early diagnosis of pregnancy of unknown location and ectopic pregnancies can prevent life-threatening complications. And hence, it's a very, very vital part of our antenatal care. And we have a huge responsibility to do it way so that we are able to give the right diagnosis to the patient. So just to conclude, confirm intrauterine pregnancy, confirm number and chorionicity, confirm viability, assign gestational age, and some basic early morphology if that is possible. So we started by saying that there's so much to do, so much to know, and so little time. But sometimes we do feel that is this a drop in the ocean or an ocean in a drop? Because in such a small scan, we get so much of information. So I would like to thank all my esteemed panelists for their brilliant inputs. And thank you very much. And thank you, SFM, for really taking this up. Very important scan. Thank you very much.
Wonderful. That was excellent. And I think, Aparna, you really led this very nicely. But we do still have some questions that we should answer, and we should eat into everybody's over dinner time and answer some of the questions in the chat box. Who's going to take the questions up?
Yes, sir.
Yeah. And
What about
the one question, of course, that we need to answer straight away is that spectral Doppler will not be used before 10 weeks of gestation, but
Yes.
color flow is completely safe, and we're not worried about that. The second thing, which has not really been brought out, is that we now have a new lexicon, a new dictionary, which is available since this year. There is the Society of Radiologists and Ultrasound of the United States of America. And in the American Journal of Obstetrics and Gynecology, mid-January this year, there is a publication which clearly says which terms should not be used. And the first thing is that we will not call the 5 to 10 week scan a viability scan, because it is much more than a viability scan, just like we no longer call the NT scan an NT scan. And then we will avoid using the words pole, so an embryo becomes an embryo, and a fetus becomes a fetus. And then those very interesting words like miscarriage versus abortion, and what Prasanna brought up, the differences between a cornwall pregnancy and interstitial pregnancy and so on. And so all of that is from the Society of Radiologists and Ultrasound consensus. And we, I think, need a full session again to cover up that topic as well. And I'm sure we'll cover it in the guidelines. If someone, maybe Aparna or someone from the Bengal chapter, can take up the rest of the questions in the chat box.
Yes, sir. So there is a question like, what about fetal tachycardia at around 10 weeks? Say 190 beats per minute. So Sitadi has already answered that it will need follow-up. So we cannot act upon that heart rate single parameter at that week of gestation. So we will be looking at the fetus again. As we know, tachycardia might be associated with aneuploidy. We will be looking at that fetus at NT scan again. So if we see small chorioamniotic separation after 16 weeks, what should we do apart from follow-up? If the separation involves site of placental cord insertion as well, is it significant?
No, I think we should just follow it up, and we cannot do anything really. So
Yes.
it's just for an observation and call the patient for a follow-up scan.
Ma'am, do you think this chorion and amnion not fusing after 16 weeks is a sign of aneuploidy also?
Yeah,
Do you think?
I think delayed fusion is a sign, but I think we will do the routine checkups and routine follow-up and not maybe do anything for this particular sign per se. But yes, it'll be like on our radar that, okay, not everything is all right.
All right. The cutoff for CRL and gestational, sir, we already answered these
Yeah.
questions. Kushagrati Ghosh sir has already answered it. Should we mention physiological midgut herniation in report?
No.
Many times patient gets very anxious. I don't think we should mention it. Yes,
True.
ma'am.
No.
If we know what is physiological midgut herniation, then we should not be. We are really sure that it is physiological. If the herniation is bigger than the abdominal circumference of the fetus, then that is not physiological. That is an omphalocele. We can label it as omphalocele as early as 10 weeks itself. But if it is very small, less than 7 mm, it is physiological, and we should not mention. Midgut herniation after 1 week disappeared. It will disappear because it is physiological. So we do need to follow up, and what else to look for. We just do routine testing for the fetus. It's a physiological thing. Any issue of safety of color Doppler for heart anomalies at 9 to 10 weeks? Yes, ma'am. Can you answer this? Even without spectral
That's just
Doppler?
been
Yes, of
addressed,
course,
sir.
because when we switch on color, the thermal index will definitely increase.
So unless required, we don't do it.
Yes, unless required, we don't do it.
So
Then
I'll
there
take
is
this
a
up
question of
rapid topic.
Case,
Yeah.
20-year-old female.
there is also this question which I think Prasanna has already answered about the white lambda meaning a dichorionic and the black lambda meaning a monochorionic.
Yes.
And that is emphasized again, and that is true. Then there is a very lovely question: how to differentiate between the corpus luteum and a true gestational sac in the adnexa?
Echogenicity. We will look at the echogenicity because
Yeah.
a corpus luteum will be more hypoechoic, and a true gestational sac in the adnexa will look more hyperechoic. As Sitadi has already mentioned, color will not help us because this ring of fire sign will be present more in a corpus luteum rather than in an ectopic. I have seen corpus luteums having more vascularity rather than ectopics. So the color will not help us. Only thing that this echogenicity thing will help us to differentiate. And if there is an yolk sac inside or fetus inside, then the diagnosis is absolutely an ectopic. But if we do not see an yolk sac or a fetal embryo inside that echogenic ring, then we label it as a probable ectopic pregnancy. That is what the new lexicon is advising us to do.
Yes. Also, the fact that ovarian ectopics are really rare. So if you find something in the ovary, that's more likely to be a corpus luteum. And how many of us have really honestly seen ovarian ectopics?
No, I have never. And we need to look at that. But this ovarian claw sign is very easily seen, sir. Like if we want to differentiate whether it is a corpus luteum or a gestational sac, we will see the ovary clawing, a part of the ovary will be clawing above this corpus luteum. So that is the ovarian claw sign which we will be seeing in a case of corpus luteum. And if it is a gestational sac, then we can move that sac by our probe movements away from the ovary. So that is what we called as the sliding sign.
Yeah.
Great.
There is also this question on how we differentiate between a partial mole from a placental mesenchymal dysplasia. And of course, the placental mesenchymal dysplasia is a much later diagnosis.
Yes.
And honestly
We
speaking,
recently reported this case, sir. I mean, we had a case in which we did, and so basically you cannot differentiate it antenatally. But what we actually do is that we do a test, we do a karyotype, we do an amniocentesis to rule out the triploidy in case of a partial mode, and also Beckwith-Whitman syndrome because it is associated with that. And then we just wait and watch. In my case, everything was normal, and it turned out to be PMDD in the histopathology also. But interestingly, the size came down as the pregnancy progressed. So I think that's how you can really, that's what you can do.
What in my experience, what I have seen, ma'am, like in molar pregnancies, right from the 8-week scan, when we see the decidua will be having multiple cystic structures in them. The placenta still has not formed, but the decidua will show multiple cystic spaces. Even if there is a fetus, then we will have to rule out a partial mole in that case.
Yes.
Right. And the last question is on, they want us to repeat the reference for that journal. It's the American Journal of Obstetrics and Gynecology, January 26, 2025. And it's the SRU consensus statement on ultrasound terms in the first trimester. And it's a free download from the AJOG. Yes.
And it also gives some new concepts about miscarriage also.
Yes, I love
7
those.
days instead of 14 days.
That's right. Yes. So I think with that, we come to an end of an absolutely brilliant. My congratulations to our Bengal team for bringing us all together and for thinking up of this very, very brilliant topic. A few words from Mohit Shah, our president, before we close.
I just need to congratulate Dr. Sita and her team. A fantabulous session. Aparna, you nailed it.
Yeah.
It was such a, I would say it was a gripping session all throughout. All your cases were fantastic. The images spoke for yourself, and all the panelists, Dr. Ghosh, Dr. Prasanna, Dr. Ananya, Dr. Arik Jyoti, everybody was absolutely fantabulous. You could take so much home out of this, when you think you have just 5 to 10 weeks scan, people tend to just overlook it. As we rightly started, you just see the heart beating and that's about it. But there was so much to take home today, and it was a fantastic session. Congratulations to the Bengal team. You've always been brilliant. You just proved it once more. Thank you so much.
Thank
you,
you.
sir.
Thank you.
It was, I think, Khurana sir to give us this opportunity and a brilliant panel moderated
Yes.
by Aparna. So all thanks to both of you.
Thank you
and
indeed.
thank you, sir.
Thank you.
Uh,
Thank you.
Thank you very much.
Thank you, Kurana sir, for giving Bengal chapter this opportunity to host this webinar, and thank you, Aparna ma'am, for this wonderful panel discussion. We also thank our sponsors, that is Strand, and we thank all the panelists who have joined it and all the delegates also who have logged in on this Zoom webinar. And thank you, Vishal, for organizing this as usual for all of us. Thank you so much.
Thank you. Good night. Bye-bye.
Thank you
Good
very
night.
much.
Thank you.
Good night.
Thank you.
Good night. Bye-bye.
Good night.
Good night.